let us get this session started. I'm David Armstrong. I am a toe doctor from Los Angeles, to translate. And it is an absolute pleasure to be chairing this session. There's some spectacular characters in here, and there's also Professor Freiberg as well. So this is going to be, you're going to be an absolute, I'm kidding. He's forgotten more than we know, and he doesn't forget anything. How was that for Bolton? But this is the session now, Proof Pathways Patients. In addition to being alliterative, I think it's going to be instructive. So I really look forward to these data on multimodality oxygen. One of the bits and pieces here that is engaging now that I've just come to understand is now the NICE have essentially certified this in their NG19, and as I understand, this is now available widely throughout NHS. It certainly is something that would be of interest to us in the US as it becomes more and more widely available. We have a terrific group of characters in here in Professor Freiberg, Mike Paredes, and Mohammed Elahi, who are going to give us from soup to nuts bits and pieces on this, all of that in the next 44 minutes and 6 seconds. Here are your learning objectives. I hope you're speed readers because I'm moving on to Professor Freiberg. Ladies and gentlemen, Freiberg, again, has forgotten more than all of us know, and he doesn't forget anything. Professor Robert G. Freiberg, who is now also the oldest program director for residents, I think, in the world at the University of Texas Health Science Center at San Antonio, generating a new bit of his kind of professional progeny. Bob Freiberg.
Thank you. Thank you, Professor, for reminding me about. He also didn't mention that I'm also training his young daughter, who will soon be subject to my what do you want to call it? My criticism. Persiflage. That is the correct word. Okay, so thank you. It's always a pleasure to be here and to speak about topical oxygen. I should say. Malvern is one of my wife's favorite places in the world. She wouldn't ever let me come here without bringing her along. So it's a pleasure to be here. I appreciate the invitation from Mike Griffiths and AOTI to present my overview of the problem here and our success with topical oxygen, intermittent topical oxygen therapy. So as we know, the problem is with chronic wounds is low central hypoxic areas, down to about 10 millimeters of mercury in the center of the wound. We know it's hypoxic. Long-standing hypoxis is an impediment, whereas short-term hypoxis is a stimulus to repair. We know that oxygen, of course, is not just essential for wound healing, but for life as well, and there are a number of oxygen-dependent enzymes that we must be cognizant of. NADPH oxidase, ATP synthase, prolyl hydroxylase, and of course nitric oxide synthesis. And this is just some of the very essential oxygen-dependent enzymes that are at play in healing our wounds. And we'll go through this in a little bit further detail shortly. But I was a skeptic many years ago after being convinced that the very poor Leslie study published in 1988, Diabetes Care, was the nail in the coffin, so to speak, about topical oxygen therapy. But that was such a flawed study. And then we kept seeing more and more reports about the benefits of topical oxygen therapy for managing chronic wounds, not just diabetic foot ulcers, but many types of chronic wounds. Do you realize the first published paper on topical oxygen was in 1969 in a very poorly known and not well-read journal called The Lancet, published by Fisher. Subsequently, you've seen many articles, more commonly in the last decade or so than we ever had before. So this is really nothing new. But the study that really caught my attention was this study by Fries, published in 2005, and he worked with Shandon Sen, a very important wound healing researcher in the US. And what they did was place wounds on the backs of pigs, and they were paired. And what was very important is that they placed an electrode 2 millimeters into the wound to measure oxygen. And they compared these wounds over the course of their healing over the course of several weeks and administered the oxygen for 7 days. And what they noticed right here was that when they started the treatment, or just before they started the treatment, the measurement of PO2 at the center of the wound was what? 11 millimeters of mercury, as we said before. And after only 4 minutes, it went up about fourfold to about 40 millimeters of mercury. This was topically applied oxygen under mild pressure. And so here we see that it did have an effect in the wound tissue itself. And if we look at this graph down here, we can see that with just 7 days of topical oxygen therapy, there was a significant decrease in the size of the wound and leading to wound closure. This is what really convinced me that there really has to be something to this, and that the naysayers can't all be right. And then we look also in the same paper, looking at staining of VEGF and controls versus the oxygen treated. I'm sure you can't see this as well, but there's significantly increased staining for VEGF in the oxygen treated groups at, I think this was 15 days after treatment. And also we see smooth muscle actin controls versus oxygen treated group, significantly more evidence of smooth muscle formation or angiogenesis in these oxygen treated groups with just 7 days of applied oxygen. And here we can see wound site PO2 at day 22 significantly higher in the treated group compared to the control, the ambient controls. Why? Because of increased angiogenesis. So there was a sustained effect here. Now, there's different types of topical oxygen devices, continuous versus the intermittent topical oxygen therapy, which is the one that's been the best studied with most robust evidence. And this is the one which is the focus of our discussion today. I'll refer you to this very good and very detailed paper just published 2026 by Lohr, and it's a mechanistic study on the value of oxygen and compression, the multimodal therapies that we're going to be talking about today. It's very, very important because the intermittent topical oxygen therapy directly addresses the multifactorial barriers to repair. The hypoxia, the lack of angiogenesis, the sustained inflammatory process, the sustained edema, which all are impediments to repair. So this one figure comes from that paper, which I think is very interesting because it kind of summarizes in a complex way the various interrelated factors that can be addressed by both the topical oxygen and the intermittent compression therapy. So we know topical oxygen is going to increase the PO2, and the increased PO2 is going to lead to upregulation of ATP synthesis and ADPH for your redox signaling for infection control, as well as endothelial cell activation, prolyl hydroxylase activation for collagen synthesis as well. The cyclical compression is very important. We don't pay enough attention to lymphedema in these patients. And the lymphedema can impair healing by sustaining that inflammatory process in the wounds and promoting residual edema with the noxious inflammatory milieu present in that edema tissue. So when we combine the topical oxygen with the cyclical compression, we resolve the inflammation and we move on to tissue repair. So I'd refer you to this article. It's very, very comprehensive, and it really very well describes the benefits of both the topical oxygen delivery with that intermittent compression therapy. But then we always have to ask the questions, because there's many wise guys in the room. Well, show me the evidence, because I need to see it. You know, we all see these white papers from companies promoting their products, but is there evidence? And we've developed a lot of evidence over the last decade or so. We published this paper in 2020. This was the TWO2 study, which was published in Diabetes Care in 2020. And this was a very robust, double-blind, sham-controlled study using a group sequential design where we compared topical oxygen, intermittent topical oxygen compressive therapy with ambient air, really, because the sham control unit was just ambient air, even though it looked like it was an active group. Our primary outcome was percent healed at 12 weeks. One of the important secondary outcomes was looking at 12-month outcomes. Now, how many studies prior to this looked at 12-month outcomes also, as well as the 12-week outcomes? In Europe, you're looking more at 20-week outcomes. And I say, how do we compare 12 weeks with 20 weeks? I don't know. But in the US, it was 12 weeks. And what we found after 12 weeks of administering the topical oxygen therapy, we had almost 42% healed versus 13.5% in the control group. Now, you might say, why is it so low? We only included patients who were very refractory to healing. They went through the typical 2-week run-in period, had to reduce their size by 30 millimeters, or excuse me, by 30% or less, using the best standard of care, the best offloading at the time. So these were difficult to heal wounds. And even with that, with the adjunctive topical oxygen therapy, the intermittent topical oxygen therapy, we had a significant improvement in healing. When we also looked at the long-term effects of that 12-week administration, maximal, we found that there was a continued sustained signal, and we found that 56% of the active group were healed at 12 months compared to 27% of the control group. So there's an enhanced signal there, and we also found there were fewer recurrences. Fewer recurrences in the actively treated group, which is an indication for the healing quality found with the topical oxygen treatment. So this is very important, and we adjusted. We had a positive logistic regression on a univariate analysis. When we adjusted for University of Texas grade, we found that the odds ratio actually increased to about 6. So there was 6-fold healing in the oxygen-treated group compared to the ambient air group. So this was very, very significant effect. And we saw in this log rank test, this survival curve really tells a story. We saw a separation between groups at just at the first week, and we can see the sustained healing. This was very, very significant, showing the difference in effect between the sham control group and the actively treated group. So this is very, very powerful evidence for the effect of the intermittent topical oxygen therapy. Am I having problems with this again? There we go. You got to press it. Okay. Rub your head. Okay. Another real-world evidence study that we did several years ago also was looking at real-world evidence. We know RCTs are not realistic in the real world because we actually have to deal with patients and their vagaries. And so this was a very large study performed in several VA systems in the United States. And they were looking at outcomes at 1 year. And the two outcomes were amputation and hospitalization. And and this was a retrospective study, we included any patient who had had the opportunity to even have topical wound oxygen, even if they had tried and failed other adjunctive agents, and compared that group with those patients who matched the cohort, except for they did not have topical oxygen therapy. And what we saw was a significant reduction in both hospitalizations in the oxygen-treated group and amputations at 360 days at 1 year. So this is real-world evidence that supported what we saw in the robust randomized controlled trial. Then we did propensity score matching of I think it was about 9 different factors. We found the same thing. We found a significant reduction in topical wound oxygen treated patients compared to those who hadn't had this for hospitalization as well as amputation. Significant reduction in both hospitalization and amputation. We further went on to do logistic regression and found a significantly increased likelihood of requiring hospitalization in those patients who did not have topical wound oxygen therapy. And we also saw a significant likelihood of requiring amputation in those patients who did not have the benefit of topical oxygen therapy. So again, very, very important real-world evidence that supported everything that we've seen in other uncontrolled studies. There have been subsequently more than 5 systematic reviews, independent systematic reviews, all supporting the role, the enhanced benefit for healing in diabetic foot ulcers in those patients using topical oxygen therapy compared to their controls. And so the data continues to be very consistent, showing a very marked signal for healing in topical oxygen-treated patients compared to those who had never had topical oxygen. This was just on diabetic foot ulcers. And the Carter study was probably the most robust because in this one, they only included published RCTs. Some of the other ones looked at a lot of retrospective studies, prospective, uncontrolled studies, but the Carter one showed, I think it was a 59% increased likelihood of healing at 12 weeks compared to those who did not have the benefit of topical oxygen therapy. So we're seeing a lot of good, robust evidence. One of the newest studies was this one, which is a large registry of patients. This is reporting on over 3,000 patients of various wound etiologies who have had the topical oxygen, wound oxygen therapy. This was also just published this year. And we can see that there were, of 5,000 patients, 3,126 had final outcomes that we were able to report on. The majority of these wounds were diabetic foot ulcers, 72%, next venous leg ulcers, arterial ulcers, and various types of atypical wounds. So what do you expect we might have seen in this variety of wounds? Pretty much what has been shown in multiple studies in the past. All total, about 65% complete wound healing, which was the primary endpoint. Mean time across all those different types is about 4 months of treatment. Diabetic foot ulcers, venous ulcers, what have you. Reoccurrence rate, about 3%, less than 3%. Pretty similar to what we saw in the diabetic foot ulcer trial. Hospitalization rate in the treated groups, also less than 4%. Amputation, about 6%. And this is for all comers. This was not a randomized control trial. This is just real-world evidence from a very, very large data set, all which is consistent with what we had seen in prior uncontrolled studies, prior prospective studies, and case reports. Very, very interesting data. And as we can see, I think the important thing for this Kaplan-Meier curve is that you can see consistent improvement in wounds no matter what type of wound they are, whether they're DFUs, VLUs, arterial ulcers, or atypical ulcers, which are usually the most difficult. But we see a steady progression towards healing in all these wounds in patients who have had topical oxygen therapy as adjunctive treatment. It's not a panacea, but it's got to be adjunctive to good standard wound care, no matter what the type of wound. And here we just see the outcomes by different etiologies compared to the wound age, and then the time to closure we could see is always about 4 months here. And in this set, there was 72% patients were healed in the VLUs, which are very difficult wounds to heal. So David wants me to speed up a little bit. I was given latitude, David, so I can do this.
But I only have longitude here in my cartographic.
Well, you're going to get a little latitude and longitude from me. Okay, so we see there's a lot of important papers that have been published and guidelines, including the American Diabetes Association Standards of Care, giving an A-level recommendation. The Journal of Wound Care has also given a grade A recommendation on their supplement on topical wound oxygen, and the JAMA paper on diabetic foot ulcers review also made a recommendation for topical oxygen therapy. International Working Group in 2023 finally made a recommendation for topical oxygen therapy. And also we see the Wound Healing Society 2023 also gave it a level 1 evidence rating. So we've seen a great deal of change in the last decade for topical oxygen therapy compared to prior decades. And of course, as David mentioned, the NICE guidelines have now been updated to include the adjunctive use or the consideration for topical oxygen therapy. Why? Because of the robustness and the consistency of all the data. So in conclusion, we know that topical oxygen therapies have finally come of age based on all the data. It's no longer considered experimental. It's, in my opinion, the data is actually better than that for hyperbaric oxygen therapy for routine diabetic foot ulcers, excluding infected and ischemic ulcers. It's perfect adjunctive home-based therapy. It's all home-based therapy, no longer center-bound. You can use it adjunctively with other advanced therapies. Very few complications, very, very high adherence rate. But we also always call for more double-blind studies. And finally, I'd like to point out that there's been a health economic cost analysis that was published in 2025 in the UK by Kerr, and I'll let my following speakers discuss that further. So with that, I want to thank you. Sorry, Dan.
Thank you very much, Professor. And not to be outdone is Dr. Mike Paredes, who's a consultant diabetologist at the Kettering NHS Trust, and he's run for almost a decade now their diabetic foot unit. I really look forward to his talk now, which is really going to be beyond the data, a DGH experience. Please help me welcome him. That was far beyond a golf clap. That was really very nice.
It's a very, very lovely environment to be in, and thank you very much for the invitation. So my disclosures, the agenda today is 2 parts. I'll be presenting the case that we've treated in Kettering and Northamptonshire, and then Mo, one of my senior podiatry colleagues, will be presenting a little bit more of the maths. Seeing as I'm Greek, I thought it would be better if someone that wasn't Greek presented the maths and the economics for integrity purposes.
What about Archimedes?
Well, you know, he wasn't, he was a little bit before my time, so.
He was Sicilian as well.
Well, debatable. We can talk about this afterwards. Stop wasting time now. So, where does it start? So the story starts with a lot of the vascular dead ends. I think that's one of the big things. Antibiotics get used indiscriminately, but the vascular supply, macrovascular, which is the key challenge here, is always going to be essentially the bridge that we struggle to cross. We know that oxygen is crucial. We know that there's been some previous, we knew that there was some previous experience with using oxygen therapy, but not the solid data that we had. And then, of course, I arrived at 2023, and Hagen heard our young man and previous speaker present this trial, and I was thrilled. I called my secretary. We need to find, you know, the relevant individuals in the UK so we can see if we can use this on our patients. So the patient selection dilemma that we had, of course, is that the trial data had a certain vascular path phenotype that was different to what we see, at least at the end of the road in diabetic foot clinics. So you had modest limb ischemia rather than a lot of times the severe and critical limb ischemic patients. So we don't use ABPIs, at least not at Kettering, TCPO2 other than Mo and his academic ventures. So really it's toe pressures and the duplex, which is kind of like the main form of modalities our vascular surgeons use. So these were the patient groups we had, okay, and across this 15, 16 patient group cohort, all of them had a variation of ischemic pain, tissue loss, at least 75%, stenosis on arterial duplex. And so we were at one of the big problems we have in Northamptonshire is the delay to angioplasty intervention, a median of 6 to 8 weeks for outpatient intervention, which is really poor, and you know, we're desperately trying to kind of improve that through a variety of measures. But at the same time, getting a hybrid theatre built and finding 5 extravascular surgeons overnight isn't something that's going to happen. So one of the key problems we had was basically admissions while they were waiting, severe intractable pain, and superadded infection that pushed them over their edge and would be, you know, the final kind of killing block. So we thought, well, maybe let's try some of these patients if we can use the TWO2 therapy to bridge them to get to that angioplasty date without admitting them to hospital. We then had the assistance in post-amputation. So you'd have an amputation of some description, be it digital, transmetatarsal, try and speed up the healing process in essentially at least micro, if not macrovascular patients. In individuals that there was no other option in terms of vascular intervention, and if, for example, a patient refused a vascular intervention, and of course we then had, of course, the chronic non-healing ulcers, which was a little bit closer to the RCT data that we heard about. The outcomes for these cohorts were essentially prevention of admission, control of analgesia, and infection in terms of the first group, and essentially the rest was essentially healing and no complication in terms of infections again. So out of these 16 patients, I'm obviously a lot shorter than you, 12 of the 16 had significant vascular disease, so kind of moves you out of the original RCT data, and that does kind of, makes you a little bit uncomfortable, but sometimes you have to try things to see how they work. And the 4 that had less were the ones in the chronic non-healing ulcers that had these ulcers for 6 months. Now, out of these 15, 16 patients, in the interest of time, I can't present all of them. So I'm going to present predominantly 3 that we've done all the financial analysis as well. So then you can then, when Mo takes you through the numbers, you've got a patient in mind. It'll make it hopefully a lot more genuine and real. In terms of group 1, the big thing really was about looking at the analgesia, and ischemic pain is really difficult to deal with. I did a stint in palliative care when I was a trainee, and I remember, the grams of syringe drives of opioids, and you would at least in those patients have some degree of management. But in ischemic pain, it's such a difficult scenario to be in. So out of these patients, they were all on paracetamol, all on opioids, at least a neuropathic agent. None were on nefopam, so we now use a bit more nefopam. And 5 out of 6 had CKD, so using non-steroidals makes it a bit difficult anyways. Pain relief, the testimonials were crazy. Particularly one gentleman, he said he was close to several parasuicides on numerous occasions. And, he was on ridiculous amounts of opioids. So the pain relief was like a huge kind of like, and the podiatrist would say to me, God, Mike, these guys are really doing a lot better from a pain relief perspective. This is one of the ladies that was waiting for her angioplasty. And then actually around 4 weeks, this is what her foot looked like. Obviously not healed, but a lot better and a lot less pain. She had her angioplasty. This is a nasty heel ulcer, obviously. And that's what it looked like 12 weeks later. The vascular surgeon didn't realize that the patient was on oxygen therapy and said, you don't need an angioplasty, actually, because it's healing on its own. And he called me and said, oh, Mike, his blood supply is fine. I said, no, that bag he puts on his leg every night, it's attached to something else. He, in the end, didn't go for angioplasty and sadly died about 3 months later because his wife had a stroke. And he then ended up in a care home, caught pneumonia and died. And it's very sad, actually. And I think for me, one of the big things is, we're seeing the patient at the end of the journey, and it'd be so much better if the patients were being exposed to all these interventions that we have now earlier in their journey. So we'll look at now the patient. So we'll look at a patient after who'd had the transmetatarsal amputation. So this chap, I'm going to flick through the images more so for you guys to see the progression. Monophasic, not a huge amount of tissue loss. They were like, okay, well, what should we do? Below arterial disease, consider management versus an elective BK. It progresses, is getting worse. He goes for an angioplasty. Deemed as a good result, as good as it can be. And to be fair, the interventional radiology guy, the lead guy we have, is exceptionally good, Davis. So I don't think anyone else could really done that much more. He ends up with a transmetatarsal because he doesn't want to have a BK. In his words, I don't want to lose my leg. I lose my leg, I die. And he's left with this kind of blunderbuss looking like foot, innumerable courses of antibiotics, non-healing. He then goes on to TWO2 within 4 to 6 weeks. And then over 3 months, bang on 3 months, interestingly enough. And he's healed 18 months later. He's not had a relapse. I hear about him from the community podiatrist. He's never needed to come back to me. His glucose control was fine, didn't smoke, so, his problems were predominantly just purely vascular, and he's improved so much and healed. And, he's quite a character, actually. He loves his Guinness. So group 2, so we had the one that healed at 3 months, one that healed at 4 months. And it's not easy with everyone. So the last patient is just healed recently. That's 13 months of therapy. So it's not for everyone. You could argue 13 months, Mike, anything else could have healed it. So, and that's a fair point to say. But I'm presenting all the stuff so, it's open to criticism and honesty. So this is interesting. So the case one that I'm going to show you now is someone who declined intervention. And one of the problems we have is because everything's done in Northampton from a vascular perspective, a lot of the patients don't want to move, don't want to travel down south. There's a bit of a postcode issue. So this is how this patient presents to the community podiatrist in December. Some skin changes there, not particularly alarming if someone just randomly saw that. But then very soon, having gone off the radar, he presents with this awful necrotic gangrenous heel. Vascular surgeons are debating, admit, not admit, needs an urgent angioplasty, do all the kind of business, glucose control, antiplatelets, all that. He's offered an outpatient angioplasty because he won't be admitted. He says, no, thank you very much. He had some debridement by one of the podiatrists to try and help with a bit of the infective burden. That's the start of TWO2. A month later, July, September, October. I mean, I won't lie to you, I was pretty surprised. But these are genuinely true. And happy to have these patients, checked to make sure we're not making things up. But it is, I don't think I've seen things as impressive. I have one other case at the end that's even more impressive. So out of the group 5 patients, all have healed. It's variable rates. The 12 weeks, it depends. I think, it depends on your cohort of patients. Massive improvement in pain control. This is a guy with an awful Achilles tendon, had 2 sets of debridement and numerous antibiotics, and he essentially was left with this kind of awful ulcer, recurring antibiotics periodically for at least 6 months. He went to TWO2, 12 weeks of treatment. We stopped at 14 weeks because he decided. He said, I've had enough, doc. This is good enough. I can go back to the Rotary Club. That was what he said to me. And I hear about him periodically, and he's doing fine. The pain relief we've talked about. So from the patients, so how are we doing with time? 13, okay. So quality of life has been the big thing for us. Pain relief, staying out of hospital, not having infections. We didn't see any individual have a myocardial infarction, which quite often these kind of cardiovascular events get associated with these nasty foot attacks. Yes, there's still more to do in terms of collecting data, and we've only kind of done the 3 cases in great depth because it involves going through 3 different organizations. Software, looking at district nurses' visits, so everything to a really, kind of close footprint. Funding-wise, although it is nice, it's still not, if you want, part of standard of care. It should be. We got £37,000 in one grant. We've recently had another grant approved. Obviously, ITOT have been very generous and treated some of our patients, and they've been very honourable. And once we agreed to start a patient, they haven't withdrawn treatment from anyone, despite if they've had to go for more than 12 weeks. And that's, credit to them. So in conclusion, before Mo takes the stage, we essentially, so we only had one patient that couldn't deal with it, and essentially he was really frail, and his sister couldn't come often enough to help him. So that was the only problem we had. We had one individual that said he didn't smoke, but then he did smoke. So we then had to kind of, get him to smoke outside. The AOTI nurse kind of showed me evidence that he perhaps hasn't stopped smoking, so we had to stop him. So there isn't a lot of problems that you're going to deal with, and because it's at home, it's what patients want. There's at least 2 BKs that would have been prevented, that were guaranteed. And I can't wait for someone non-Greek to show you guys the maths and the finances and the dollars, pound signs. So I'll give you over to Mo, who's going to present the finances around the 3 main patients that I showed you. Thank you very much.
Evharisto. And there we are. And here comes Mo Elahi, ladies and gentlemen. Please help me welcome him. Looking sharp, man.
Oh, thank you. Had to. It's the Malvern. So So I'm going to try to be quick, just mindful of time. So I'm going to go through the numbers with
Please, for Bolton's sake. He's going to have a TIA back there. He may have already. Can someone check on him?
So before I start, so I'm going to say to you, like, what if I told you that within these 3 cases I'm going to discuss, within the NHS, we could save £150,000 within this treatment period for these 3 cases? And we've saved 3 legs from amputation, because that was the ultimate plan. The end game was these patients either weren't fit for surgery, they declined surgery, or they were too complex and they were slated for below-knee amputation. So we salvaged 3 limbs using the TWO2 device. So this is not a hypothetical. This is what I will talk through with a few minutes of this talk and go through the numbers of financially how I came up with the figure of 150,000. So if you look at this slide here, which talks about the methodology we used. So I got the reference costs from BNF, from costings from oral antibiotics to IV antibiotics. We looked at EMIT, NHS supply chains, from dressings to ISD Scotland, tariffs, NHS England reference costs with regards to what does it cost for a podiatrist, for a consultant-led MDT clinic. And the costings that are outlined at the bottom, I think you can see them. Major amputation of 32 to 65. So within this calculation, I've used 32. So conservative figures. We've not inflated the figures to make it look like, you know, of wow, it's like a significant amount of savings compared to, you know, what is as a real world saving. Diabetic foot clinic, it comes to £351, which is a single consultant-led clinic. And in our setting, we have a antimicrobial pharmacist, we have a consultant podiatrist, we have a consultant vascular surgeon, a consultant diabetologist, and we have a couple of band 7. So that £352 per session is under what the actual real cost is. So just to give you an idea, because when you see the numbers, they're quite staggering and quite significant. And also the oxygen therapy. So I don't know what the real, so forgive me, Rob, for quoting the figures, but we were charged between £500 to £2,000. And that's the generosity of Aortic, who, you know, subsidised some of it, sorry. And that was £500 per week to £2,000 a month on average. This is what it cost. And an OPAT, an outpatient antibiotic therapy session, we priced at £831. Okay, so going to the first slide. So this patient is RB. RB had a post-operative TMA, a transmetatarsal amputation. The surgical wound would not heal for 5 months. So we use that reference point. So we've based these costs 5 months as a snapshot of what it costs to treat that patient. Their regular weekly visits. On average, they were coming in about 2 to 3 times a week for dressing changes and also community visits with the district nurses, the consultant-led clinics. The cost of antibiotics, we broke it down to orals, the IVs, and the cost of OPAP. And the only option for this patient was a below-knee amputation, and then we started TWO. So with topical oxygen therapy over a 5-month period, the clinic visits and dressings, you know, significantly dropped. It basically, so before TWO, it was about £7,000. Antibiotics were £17,000. The looming below-knee amputation, which was the plan from the conservative figure of 32, gave us a total of £56,544. Once we started the topical oxygen therapy over a 5-month period, we reviewed their attendances. Their clinic visits had halved. So from 2 to 3 times a week, they were coming once a week. And then eventually, as the wound was epithelializing and healing, it was fortnightly visits. So a significant reduction of clinic visits within the community. So that reduced the burden of care upon our district nurses, our GP practices, and our community podiatry clinics. It also reduced the amounts of the relapse in the infection, less query with the acute, with admissions to OPAT, to A&E. All that attendance had reduced. The antibiotic cost for this patient from the £17,000 within that 5 month without the therapy had dropped to £20. So the patient had only had 2 courses 2 weeks of oral antibiotics. So from that 5-month period, they didn't have any significant infection. The TWO2 device itself, we had spent £10,000 for that patient over that period, and no amputation was needed. And that's the reference picture for that case. Okay. So the next case, patient MT. So this patient had a chronic heel osteomyelitis, which is confirmed radiographically, with critical limb ischemia for more than 3 months. They had confirmed bone infection with degradation on their serial radiographical images with critical limb ischemia. Without intervention, the risk of major amputation was over 50%. They were offered an invasive angioplasty, but the patient declined. That is the patient's right, and they have their choice. So we tried 12 weeks of this oxygen therapy, which resulted in complete wound healing. So without the oxygen therapy, the cost of, the aggregate cost of all that, MDT appointments, clinic visits, IVs, OPAT, the declined angioplasty and the looming amputation was a sum of around about £64,000. With the oxygen therapy, we only spent £7,000 during that period. So the net savings for this case was £56,335, and that was achieved with 0 IV antibiotics therapy during that period, an amputation avoided, and the patient's choice ultimately respected. Okay, and that's the picture again for reference. Next, last case, this is probably the most complex case, patient AB. They had a gangrenous heel for over 12 months, and there was they had over 110 days of IV antibiotics during that 12-month period, which is a significant amount of IV antibiotic burden, and also the time used within an acute setting. A 20-day inpatient stay during that period, an A&E visit, and a surgical day case for the debridement of that heel. So the system in North Hampshire was throwing everything at this case, which was futile, and an amputation was discussed as the only remaining viable option for this case. Then we started the TWO2 therapy, which was 21 weeks, which was ultimately resulted in complete wound healing and holding for 12 months and counting. And for all 3 cases, they've all remained healed, and it's true to Professor Freiberg's data from the RCT and the real-world studies. From these case studies, we've replicated that. So these cases, they've all remained healed and none have relapsed. And just a breakdown with that cost, before TWO2, the inpatient stay in A&E was about £11,740. Surgery was £2,000 for the day case procedure. IV antibiotics and OPAT costings were a large sum of £57,000. And with oxygen therapy, the MDT involvement during that period was £1,760, and topical oxygen £10,500 during that period, which gives you a net saving of £60,000 for that case. And that's the reference picture. Side by side, all 3 patients ultimately show that, they're all 3 different varying presentations, a mixture of osteomyelitis, chronic infections, all sharing varying levels of end-stage critical limb ischemia, different timescales, 5, 3, and 12 months of, protracted healing. But look at the savings, 43,000 in first case, 56 in the second, and over 60,000 in the third. All 3 amputations were avoided, 3 out of 3. Antibiotic burden collapsed and disappeared in every case. That's a striking thing. So, physiologically, there must be something going on where the oxygen, I don't know what the physiological data says, but that's quite striking. None of them had any infection. And also, during the pre-period, when a wound is that end stage with set-in gangrene, there's also a panic where staff then refer, it's getting bad, it's getting infected, needs antibiotics, and where's the burden of proof? Is it infected or is it not infected? And so there might be true infection where we're treating that infection, and a lot of the cases it was safety netting from community practitioners who aren't specialists, and they were referring these patients in where there was a rotting limb that was being referred to A&E. And in all cases, there was no need for that, and there was no escalations, as reflected by the reduction in community visits, extended time at those wound care clinics, and ultimately the proof of the pudding, the healing in all three cases. In an era of antimicrobial resistance, this is a public health win on its own as well. So the headline, the aggregate impact is that 159,000 saved across the three patients, which is quite important because, like, a lot of you in the NHS, like, funding is a big thing, is a dirty word, and there's a finite amount of resources, and management will come back and say, look, we're not going to fund this. But it's just creatively building your business cases, because, like, give an example, like maggot therapy, £300 to £400 a bag, to treat these patients over a week. We might use maggot therapy, larval debridement, for over 3 weeks in these patients. And as we've just shown, a £500 for topical oxygen therapy, just substituting one adjunctive therapy for another advanced therapy, that is a cost difference. And then if you can replicate that in your centres and show that to management in business cases, they will approve this. Also, it's on, is it like weekly coding now on NHS supplies? Yeah, and so then the other issue is getting the funding when it's more than £2,000 and the budget holders can't approve it. Having that facility where it's under £1,000, it can easily be ordered on NHFD supply chains, and that's something that you can work with your procurement to get this onto your formularies. And things that we can't put a pound sign on: the quality of life preserved in all those cases, limb salvage in all cases where that was the inevitability of their presentations, antibiotic stewardship, protecting drugs we can't afford to lose, a smaller carbon footprint, fewer hospital trips, care close to home. And it can be applied over whatever therapy that's happening, so they can be fully bandaged completely. And this oxygen tent is put over, compressive therapy, but still it will work, and the oxygenation will get to the wound and treat that area that's completely enclosed. And patient choice is respected in many of those cases. And that's what value-based care actually looks like. References, thank you.
I want to thank all three speakers.
I promised a case.
Oh,
I promised a case I will show
here we are. Very good. One more thing, I suppose.
Who knows what this is? That's why you're that's why you're the boss. Yeah. So pyoderma. So this poor lady, the story is, my secretary got a phone call from one of the tissue viability nurses and said to her, Alison, Dr. Paredes had a patient many years ago with diabetes that was on dialysis. And I looked after her. She had calciphylaxis. It was really difficult to manage. And her daughter-in-law used to always bring her to clinic. And she said to her, that daughter-in-law is under dermatology with pyoderma, and she was wondering if Mike and his team would come to see her. So I called Mo, we called Rob, Manon, who's here, our trust grade reg, and we went with the team to see this poor lady who was unrecognizable. So her mother-in-law died 3 years before this, and in her prime, 38, could have modeled, completely unrecognizable, severe Cushing's from drugs, every disease-modifying kind of immunotherapy side effect she could have had. She had pancreatitis, 3 abdominal surgeries, an absolute mess, and her pyoderma was only getting worse. She'd have been on every antibiotic you can imagine. The vascular surgeon came and saw her the same day, said, the vascular supply is not an issue. We saw with Said, our orthopedic consultant, because there was a question, is OM, is this not? Clinical radiology, not the case, so what do we do? And she was on ridiculous amounts of opioids, Penthrox and all sorts, and in agony. She couldn't even sit up in bed, couldn't sit out in a chair. And the only thing we changed with this lady is that we put her on TWO2. And probably the main thing that changed is that for those of you that know pyoderma, you've got to be really careful of doing any form of sharp debridement because you make it worse. which is the exact opposite to how we treat diabetic foot ulcers, debride. But with pyoderma, we've got to be really careful what you debride because you can make matters worse. But obviously, this amount of biofilm needs dealing with. So she couldn't even let people come close to her. Going on to the TWO therapy, this is what it looked like 4 weeks later. Now, the only thing that I would say was different is that because she went on to the 2, Mo was actually able to debride some of that stuff. But other than that, and yeah, so she was able to actually get out of the bed and sit in the chair for the first time in months. Very, very sad. And I mean, the only sad thing is sadly that this wasn't available to her earlier, because we didn't really do anything major intellectually. We gave her, a nice inflatable sock with oxygen, and it worked wonders. And sadly, she died 2 months later, before she could benefit. She had renal failure, fluid overload, recurrence of her pancreatitis, very sad. But I mean, the key thing is this, and then that in 4 weeks. So this is when I say I think we're really privileged in this day and age to have new things coming out that we can offer our patients. And I'm hoping that, and this is worked presumably that well also because the blood supply wasn't as much of an issue from an arterial. So imagine what we can do to the venous leg ulcer community. Complete, no ownership. They're not under a single consultant. In and out of the hospital. They suffer with pain a lot more because the diabetics, unless they're ischemic, they don't really have pain. But the venous patients, they're awful venous ulcers, awful antibiotic stewardship. So that was
Mike,
the impressive
and
one.
here's to that, and here's to making a difference for all of our patients. And here's to a chock full of data and emotion session here, and Greek.
Thank you very much.
I really look forward to the next session now. Here we go.